welcome to Pennsylvania Crossfire. I'm Buddy Lesevoy, a local attorney, and I'll be your moderator today. Pennsylvania Crossfire is brought to you by this station and our sponsors to air important issues of the day. Today, we're delighted to have three Philadelphia physicians with us as special guests. First, I'd like to introduce on the left, Dr. Stephen Hunt. He's an MD, PhD, with scholarly interests in optimized drug delivery for cancer patients. He enjoys conspiracy theories, believes data and democracy can solve any problem, and although he refuses to align himself with any particular ideology, Dr. Jha, who you'll meet in a minute, believes he's a secret admirer of the Austrian School of Economics, but he refuses to admit it.
Thanks,
on the right, we've got Dr. Paulo Nucifora. He's also an MD and PhD. He has scholarly interests in post-traumatic stress disorder, an unabashed Keynesian, noting that there are very few people who actually understand Keynesian economics. He believes that Ronald Reagan was a closet Keynesian, and he thinks science can solve anything. And finally, next to me is Harry Jha. He's also an MD with an MS degree. He has scholarly interests in value of information, a tireless contrarian. He believes that we need to temper our belief in data and judgment when used common sense and judgment. And he asserts that Hayek's The Use of Knowledge in Society should be required reading. Today we want to discuss Medicaid expansion, and I'd like to start with Dr. Hunt and just ask you if you would please set the stage for our audience.
Sure. So Medicaid was a program established at the same time as Medicare under the Johnson administration, really to cover what was considered the really neediest members of society who were not in that age gap that would be covered by Medicare. And so we're talking about pregnant women, children, and really the blind and other folks with major disability. And to date, there's been a lot of, it's a program that was set up to be cost sharing with the states, and it varies state to state in terms of how much federal grant funding you get for it versus how much the state puts in for it. And so in general, it's never less than 50% that the federal government provides, but it's upwards of, in some cases like Arkansas, 75% is provided by the federal government versus 25% by the state. In a state like ours, it's more 55-45, so the state provides that. In the state of Pennsylvania, we spend a little over $20 billion a year on Medicaid. And Medicaid has been definitely ends up being a major part of state budgets and ends up straining the state budgets. And so it's always been a contentious issue in terms of any kind of expansion just because of the budgetary matters. Now, under the Affordable Care Act, the big dictum really was how do we capture and provide health insurance for the 41 million Americans who don't have health insurance. And one of the big pushes there was by expanding Medicaid to the very poorest of the poor, namely folks who are less than about 130% of the poverty limit. And so how this was going to be done was that the federal government set up a way in which they would pay for the early rollout of covering those folks for the first couple years. They'd pay 100% of the budget instead of this 55-45, and then it would gradually go down to where they're paying about 90%. So when they proposed this plan in the Affordable Care Act, the states, several of them sued. They said we don't have the budget in order to expand Medicaid to these folks. And the federal, it went all the way to the Supreme Court, and the Supreme Court basically said, while it's not illegal to have the Medicaid piece, the states have to opt in. And so it allowed the states then to opt out. That sets the stage for our own state here in Pennsylvania, where initially the governor decided, being a Republican governor, with many other Republican governors, decided it wasn't fiscally responsible and that he wanted to find some other way of managing the uninsured rather than expanding Medicaid. The issue is that there was a very big hammer behind the expansion. And part of it was what I told you, that you have this 100% funding mechanism, so it ends up being many, many billions over the course of about the first 10 years. While the state would put in about $2.8 billion, the federal government would put in about $40 billion towards managing the uninsured here in the state of Pennsylvania. And so eventually the governor did capitulate and came up with an alternative plan, namely Health EPA, for managing Medicaid.
So why are doctors generally opposed to Medicaid?
I love the way Dr. Hunt has described this whole thing as a halo sort of scenario almost with the virtuous nature of Medicaid. Medicaid is a program that has extensive good intentions, but good intentions aren't enough. When you end up paying physicians 29 cents to 52 cents for every dollar that one pays gets paid by private insurance, there's going to be a problem of access. Simply giving somebody a Medicaid card and saying, great, you're covered, that is not good enough. You have to get them access, and the access is a problem. And not only that, Medicaid, and studies have shown this, being on Medicaid doesn't necessarily make somebody hugely better off. than somebody that's uninsured. And why that is for very complex reasons. I'm not going to say that it's better to have no insurance whatsoever, but the point is that physicians don't take Medicaid.
I think it's important to be careful when interpreting some of these studies. I mean, I agree that Medicaid has some problems, but some of the criticisms that have been directed towards Medicaid have come across after a study that was recently published detailing the Oregon experience with Medicaid, in which basically they had sort of a natural experiment in which some of the population was allowed to go into Medicaid and some weren't. And I think the study that you're referring to showed that they couldn't detect a difference after 2 years in some of the major health outcomes. Not all the health outcomes are the same, but many of them. And one of the problems is that the sort of things that they looked at, including blood pressure, diabetes, blood sugar regulation, and things like that, were measures in which most of the population was healthy. So if you have 85% of the population, or even up to 90% of the population with normal blood pressure, you wouldn't necessarily expect to see a reduction in blood pressure after 2 years across the population. What they didn't necessarily look at is in the patients who had high blood pressure, whether those patients got better or not.
Yeah, but this is it, Professor. You're like Professor Calculus. You have to dissect the study and find faults in it. The point here is that we had this huge hope that putting people on some sort of insurance like Medicaid would, for example, reduce ED utilization, but it didn't. You can't deny that it didn't. So the point I'm making over here is that there is a structural problem with Medicaid. And ideology sometimes is so overwhelming that one doesn't look at these structural problems. Even now, I fear that one of you two is going to say to me, are you going to send the poor to the workhouse? I'm surprised Dr. Hunt hasn't said it already. And I would say that look at Medicaid, look at what it is, look at what it does, and there are two big problems. Buddy, firstly, it doesn't pay doctors enough. If that wasn't bad enough, if that wasn't a foot on somebody's neck, it burdens them with a ridiculous regulatory burden. In order to get a test, in order to get the right drug, they have to prove that they're virtuous, they're not, aligned to some sort of drug company, and it makes things a lot better. I mean, surely when we are dealing with the poorest, most vulnerable, and I presume that both of you guys are in support of dealing with these guys, one must make it easier for people. Why reward them the least and make life difficult? Come on, put your money where your mouth is.
Harry, I think you're talking a little bit out of both sides of your mouth. On the one hand, you'd like the fiscal nature of how do we keep costs in check, which is the reason why there's been the regulation related to it. And on the other hand, you would like to point to the way in which Medicaid has been structured to date. Part of the way that the ACA changed it was by providing price parity with Medicare for physicians. So that's one of the things. One of the big changes is that physicians under the new Medicaid rules will be paid more. Number two, you're talking about access. I agree that access to health insurance is not access to a physician, and that is a big problem. And that is going to be a problem going forward, which is why the ACA has all of the provisions written into it that have been attacked from the right about how we're going to expand the medical home and how we're going to fund that mechanism of allowing for more coverage for physicians to get into primary care.
Well, on that note, let's take a break so we can hear from our sponsors that make the show possible. Please stay tuned. We're coming right back. Welcome back to Pennsylvania Crossfire. Today we're discussing Medicaid expansion with our three favorite doctors from the Philadelphia area. And Dr. Jha, we went into the break on money and regulations.
Buddy, Dr. Hunt, you know what he does? He basically says, from the right, as if, the right really wants to put the poor back into the workhouse. Let me tell you this. The poor are a disadvantaged group. I'll be the first to admit it. And not only are they disadvantaged, because of being disadvantaged, they have a lot of health problems. They are a difficult group to manage. Not difficult in the sense that it's not rewarding managing them, but they have lots of issues. The more educated you are, the more empowered you are when it comes to healthcare. There's no doubt about that. There's nothing wrong in saying that. So the people looking after this segment of society should not be paid the least to do so. That is my point. And when you do that, it tells me that all you're doing is moral grandstanding. And you're not really getting to the nitty-gritty of the issue. And the nitty-gritty of the issue is this: whether we like it or not, the prices are set by private insurance. You get a certain amount of money from private insurance. You say, well, you shouldn't get that. Okay, what are price signals? There are no price signals. You get some money from private insurance, and Medicaid pays you 29 cents to 52 cents of that and shoves you with a bunch of regulations, and you wonder why doctors don't accept that. Doctors are not Mother Teresa. They have debts to pay. They cannot do that. And it's ridiculous expecting doctors to do that without fixing that particular reimbursement problem.
But Harry, I mean, you're talking about a private practice scenario that is such a minority of medicine in the present day. The whole way that medicine has gone is towards accumulation and conglomeration into these large bodies of doctors, for example, healthcare networks. And those healthcare networks, when they go to negotiate with a contractor like Blue Cross Blue Shield or any of them, they are forced to take both the Medicare plan as well as the other more premium pricing plans that they make their money off of. But what you realize is that in the end, when the government has a certain policy bent, what they have to do is figure out a way in which they can get the folks into the system. And while you say there's no data showing that the Medicaid folks do better than uninsured, there's tremendous amount of data, thousands of papers written about when you have Medicaid versus having no insurance, your access to a physician, your ability to your feelings of self-worth and ability to not be in debt related to medical care. All of those things do reflect back to Medicaid, and so that literature is out there. You're simply ignoring it, and that's where this plan, what the whole point is to allow these folks to get into the system, and then we will work on those other problems you're talking about, like access.
And just to go back to a point you made earlier about the study showing increased ED utilization after patients were enrolled in Medicaid, in a way, that shouldn't be unexpected. I mean, EDs bill patients just like uninsured patients, just like they do everyone else. So if you have a new mechanism for being able to afford ED care, you'd expect that someone would make use of that and perhaps increase their utilization.
Yeah, do you expect us just to have the insurance, but then people not to use it? So the point is just to have the insurance. I mean, which one are you arguing for? I mean, here you give them insurance, they go to the doctor. Not surprisingly.
Yeah, it's, buddy, I get attacked.
Conspiracy theory.
I get attacked from both sides. I'm used to it. But you recall that Dr. Hunt used the word forced, right? So that's taken your voluntary aspect out of it altogether. Look, what I'm saying to you is simply this, Stephen and Paolo, but Stephen mainly. I'm saying that when you are looking after the poorest section of society, be honest. Don't try and cut corners. Say that this requires effort. This requires money. This requires us paying physicians adequately. Cutting corners is not doing anyone any favors. It's basically trying to get out of it and then saying after all of that, look, Medicaid, look how great a job we're doing. Look how efficient we are.
I want to go back for a second because I'm still even perplexed by the realities of how the system even works. Because you described, you mentioned Arkansas versus Pennsylvania and the proportionality, if you will, of the federal reimbursement to the state contribution. Sure. And there was a dramatic difference.
There is a dramatic difference. It has to do with what is the per capita income of the state. So, for example, buddy, let's think about Arkansas. 25% of the state of Arkansas qualifies for Medicaid. Under the 138%. That's how poor the state is, okay? So you have a huge portion of the population of that state that's simply not insured because if they make the federal poverty limit is $11,000 for a person, okay? Imagine that. You're trying to live on $11,000 for an entire year, okay? These folks, they have no money to go to the doctor, and so they simply don't. And then what ends up happening is because they never talked to their doctor about that cough when they first started having problems with their emphysema, they never had the preventative medicine discussion, and they ended up with the lung cancer that ends up costing the system a ton of money. And so what happens is those states, they basically looked at that calculus and they said, we can't walk away from the money. The same thing happened to this governor. Now, we've lost $2 billion already this year in the state of Pennsylvania by not recapitulating at the beginning of the year. So we've already lost that $2 billion. That's a sunk cost. Now what we're trying to do going forward is Governor Corbett's plan basically allowed for some cost-saving measures. Most of what he submitted, he had 13 amendments to how he wanted to expand Medicaid. He basically got 3 of those partially watered down in terms of the amendments that he wanted in terms of making Medicaid. And what he did was he said, we're going to take and make a new bureaucracy, a separate system of paying a private insurers to accept that form of insurance. They're going to take the existing Medicaid folks and cut their benefits and stick them from the 7 plans that they're in right now with health insurance providers, cut those HMOs down to 2, a high risk and a low risk pool, and your benefits would be cut under his plan. And so that's where you're going to see the argument going forward. If the governorship changes, what you're going to see is that the new governor may just reject Healthy PA and say, no, we're going with the straight Medicaid expansion plan. We're going to go with how it was originally intended, take all the exchanges that we already have Medicaid on, and we're going to roll all of our 600,000 uninsured Pennsylvanians into those plans.
Seems like an unaffordable proposition at many levels.
No, the issue here, buddy, is this. I think that, let me give you a little bit of background. I grew up in the UK, I trained in the NHS, my extended family's from India. We've actually seen the consequences of the relationship of medical care with the ability to pay for it. I've also seen the relationship of medical care with other elements such as education. And remarkably, it's related, I should say, unremarkably. And I think the point I'm making over here, a lot of points Stephen's making is very much political in the sense that the governor should have taken it up and so on and so forth. But I'm making a much more of a structural point, which is that you're dealing with some of the most vulnerable sections of society. Don't try and undercut the price. What do you gain from it? And the point that I've never seen being addressed by the progressive press, and I know he thinks I'm conservative, and I'm actually just a pain in the neck contrarian. I would say that people should ask themselves this question. The physicians want to really take care of sick people. They don't want people to be sick, but it is some sort of redemption of our training that we deal with somebody that's got an illness and we fix it. I know for myself that I don't like seeing healthy people's CAT scans. And the thing is, why are people not taking Medicaid patients? Are people evil? No. I think physicians aren't taking it because there is a twin evil of low payments and high bureaucracy.
All right, and just to be clear, the concept is, from an economic perspective, that if you have a good, solid insurance, the reimbursement rates are whatever they are, but something less than 100 cents on the dollar. And worse than that, on the Medicaid reimbursement, it's somewhere between 30 and 50, give or take, % of what insurance might have otherwise paid. And you mentioned, a reference to uninsured, but presumably they're getting billed 100% because they've got no one fighting the cause to try to negotiate down to a more realistic insured reimbursement.
Exactly. And so you can imagine what it is for those families. You're making $11,000 a year, and suddenly you walk into the hospital and you get a $15,000 bill, and that happens every day.
All right, please stay tuned. We're going to come right back, but we want to take this break so we can hear from our sponsors that make this show possible. Hello and welcome back to Pennsylvania Crossfire. Today we're discussing Medicaid expansion with 3 doctors from the Philadelphia area, and we've had some great discussions so far, but now we're looking for some solutions. Paulo, please tell me what you think the solution is to the Medicaid expansion problem.
Well, as I said before, Medicaid is not perfect, but when we find fault with it, when we criticize the way it works, we should put into context of potential alternatives that would be feasible. So, it would be great if we could pay doctors more for treating Medicaid patients, but where does that money come from? I think the important thing here is that we don't unnecessarily burden Medicaid patients more as a result of reform by adding elements to reform that aren't really related to health care. So adding things like work requirements or other potential ways to restrict patients from using it, it doesn't really help. It may save on the costs, but it doesn't really help the patients. Other than that, there's a lot of different ways to approach this problem to reduce some of the regulatory burden and make sure that doctors get paid for treating these patients.
All right, I'm seeing an alignment here.
Yes,
Hunt?
I mean, first of all, the majority of patients who get Medicaid have a working family member. And so we're not talking about, as has been ballyhooed in the press, about folks who are unemployed. You are talking about people who are underemployed, and that is a structural problem. But the prescription that I would make is there's a lot of things that were written into the ACA for the folks who go back and read it that see that we are talking about price parity for physicians, but expanding access to care has got to be looking beyond the box of just physicians. We're talking about nurse practitioners and other mid-level providers who can serve as that medical home for people and allow them to coordinate their care better. And that's what the system is designed to do. In the end, what we need is the intransigent governors who are last holding out, Florida, Texas, those kind of places, to consider their hundreds and hundreds of thousands, and in this case, an additional 6-7 million people who are not having access to care because they're blocking it, okay? And those are the folks who really need some kind of level of insurance so that they're not stuck with that amazing doctor bill when they show up for critical care.
Last but not least.
No, I do agree with elements of what my colleagues have said, which is notably that you have to pay physicians an adequate amount to deal with these people. An adequate amount doesn't mean you need to pay them 5 times what they normally get, but you need to pay them 80% of what they normally get, 90% of what they normally get, not 50%. You don't want hospital administrators, we're not in the know, I don't know when a patient is Medicaid, we don't want hospital administrators to say, oh no, he's a Medicaid patient. We want it to be incidental. And the way to do that is to increase reimbursement. Now, the second component needs a nuanced answer, but I can't really give you one, buddy. But I can tell you one thing. The regulatory burden is too much. It's ridiculous what the form filling one has to do for the low reimbursement ones gets. And you have to use common sense. I can't really define what common sense is. I can say that if you have to write 3 pages of why you've provided a treatment that's going to get you $10 reimbursement, the people won't see such patients. It's simple. It's economics in a sense. So you have to reduce regulatory burden. And third, and not least, do consider the fact that that Medicaid patients have strong agency. Give them a voucher. And I know that the moment I say voucher, the V word, Dr. Hunt here gets really excited. Not in a good way. But voucher means that they're sovereign to their own health. Give them a voucher. Treat them like an intelligent human being, which I'm pretty sure they are.
And what you will find with that is that the cost overruns in the state that has tried it. Arkansas has tried to go that way of providing vouchers, and already their rollout of their version of Health EPA has failed, and the gentleman had to resign because the cost overruns were with immediate, and month after month after month they ended up in the hole. So what you're going to find is that in the end, this is the most economical way. And while it isn't perfect, I'm sorry that the physicians have to suffer. My wife, she works in a federal health clinic. She prays for the Medicaid patient to come in. At least it's someone who has some form of insurance. A large portion of her population that comes in has no insurance, and they pay what they can, $20, $25 to see a physician. But that in and of itself, at least those folks who come in with Medicaid, she sees tons of them. So maybe the rich private practice that you talk to says, I don't want to see those poor little people.
You're such a
but really what we're talking about is the vast majority of people, when they come into my hospital, I have no way of knowing as a physician whether they have Medicaid or not, and I see them regardless. And that's the way that the system actually works, Harry. It's not like what you're talking about in some very small minority of private practices that say, we don't want to see Medicaid patients because they don't pay us enough.
But you must let me speak. You must let me speak, because everything you said is accurate, but not fully accurate. I can tell you of one physician who sees indigenous populations for free, but will not see Medicaid patients for free because a primary care physician, because to see Medicaid patients for free is fraud. You have to really ask yourself, who put this regulation in that leads a physician, an intelligent person, to come to that conclusion? There's got to be something wrong with the system.
I now agree with you there. If there is a regulation such that is the case, I'll agree with you that regulation needs reform. But to say that we're not going to insure 600,000 Pennsylvanians because you want to find out some more expensive way of giving them a voucher and having them buy it on the exchange. That doesn't make any sense to me. Here we have a mechanism. We already have the HMOs that are willing to step up to the plate and do business with the government and have these folks get insurance.
What I'm saying, Dr. Hunt, is put your money where your morality is. If you think that is the way it is, put the money there.
In my household, it is. My wife works and sees a lot of Medicaid patients.
Well, so my lay perspective is that at least the nonprofit hospitals I'm aware of, they see anybody that comes in with any problem, whether there's insurance or Medicaid or nothing.
Only for emergency care. Only for emergency care. So there's something called EMTALA, and that's a little bit separate for your viewership. If you come into the emergency room, they have to provide emergency care. But for preventative care or for routine medical care, they do not. And so what you'll see is hospitals decide which forms of insurance they'll take, and they cherry pick. And that's how it's done.
Well, unfortunately, that's all the time we have for today. I want to take this opportunity to thank our viewers at home for watching, and I want to thank our 3 doctors from Philadelphia, Drs. Hunt, Dr. Nusafora, and Dr. Jha, all for joining us today. We hope that you'll tune in next week for another great edition of Pennsylvania Crossfire. This is Buddy Lesevoy for Pennsylvania Crossfire, hoping you have a great week.